Morning, everybody. Thank you so much for coming bright and early on this Sunday. My name is Desai from the Cleveland Clinic, and my good friend, Dr. Anjali Owens from University of Pennsylvania. You will hear from both of us through the hour, which we hope is going to be engaging, fun, along with learning. And for the next 60 minutes, we will not be thinking about TSA lines that wait for all of us, right? So what are we here to talk about? Cardiac myosin inhibitors in HCM, how they have come about, and more importantly, where we are going with a lot of real-world data. We would like, of course, you heard from our good friends Mended Hearts, but also like to thank PeerView for the session and Bristol Myers Squibb for sponsoring this. Looks like everybody is well versed with the QR code and the QAs and the lottery drawing that was discussed. And for the virtual learners, please respond to polls on your screen and enter questions in the chat window. And the in-room folks, you have the QR code. So there's the $50 gift card business quickly before it goes away. And there's the obligatory where you can get all the materials. Mended Heart, as they are a not-for-profit organization who are doing absolutely wonderful things for patient advocacy. They are the voice of the patient. So what do we want to achieve today is a lot has been said, a lot has been written, so how do we merge everything? How do we apply guideline-directed approaches, including imaging and novel technologies, for timely diagnosis and management of obstructive HCM patients? Where is the data? What is the real-world data? And how can we leverage all this for a team-based, customized approach, which incorporates everything? Ultimately, all of us are in the room here because we care for our patients. And we want to make sure that person walking out of your office a few months from now is feeling like $1 million. So, at baseline, I am a multimodality imager, so how I approach patients, but I'm also a clinician and do occasionally some research when I feel like it. But it starts with diagnosis. That is the entry point, okay? So how do we make the appropriately early, appropriately timed diagnosis for HCM? Again, I'm from the Cleveland Clinic. So HCM is not a one-size-fits-all, right? All of us have patients that span the full spectrum. You could have a normal-looking heart to a very thick heart. You could have reverse septal curvature. That is the classic thing that we look out when we are thinking about HCM. You may have apical variant HCM. There may be obstruction. There may be non-obstructive HCM with the cutoffs being 30 millimeters of mercury. You could have mid-ventricular obstruction. So fundamentally, you could have reverse septal curvature with obstruction or without obstruction. So it is important as a branch point to make sure you diagnose obstruction accurately. And then there is the latent obstruction, and we will briefly talk about where it does not appear obstructed on a naked eye. You do Valsalva maneuver, does not obstruct, and then you put them on, but they have symptoms. You put them on a treadmill or an upright bike, and there comes Sam. So we have to be able to characterize these patients very appropriately. Now, but I want everybody to go a little deeper into it. Where did this business of 15 millimeters and 13 millimeters come about? Do we know? In reality, that came from a paper in 1973, which included about 15 patients on M-mode echo. I'm not joking, okay? I'm not making this up, okay? That's the genesis of the diagnosis. How many of you have suits that were made in 1973 with that BGs or bell bottom or whatever?
I got one in the back there.
You got one, right? I got one. No, I don't. So at the very least, we have to fundamentally rethink how we are thinking about HCM, right? So along comes this paper, leveraging cardiac MR or advanced imaging, leveraging artificial intelligence, machine learning, all the buzzwords of 2025 and 2026. Essentially, taking the UK Biobank data with healthy cohort and HCM patients and coming up with specific thresholds. What they found was about 35% of variability in LV wall thickness comes from age, sex, body surface area, right? So we may be in a future state, a couple of few years from now, where you plug the patient's measurements in a formula, and then that gives you a probability score whether or your patient has HCM, with women more likely to be diagnosed at a lower thickness than men. So this is a fundamental way of thinking about it. How many of us don't use cholesterol equations to ascertain risk of CAD? We need to be moving towards that, and we are. This is an equal opportunity offender, all ages, sex, and races. It is not rare, but most certainly clinically underdiagnosed. Prevalence 1 in 200 to 1 in 500, about 700,000 Americans. If you just look at the world's population, we are now talking millions, right? Median age of diagnosis of a genetic cardiomyopathy is 46 years, meaning for the first 46 years, we were trying to figure out what the heck was going on with the patient, or maybe there's late presentation. But often it is a misdiagnosis. 2 cases missed for 1 correct diagnosis. And there are major disparities. The social determinants of health, insurance status, rural, this, that, all of us know, talk about it, but not much is done about it. What is important is a third have significant obstruction at rest, if looked for carefully. Third, truly non-obstructive, and a third have about latent obstruction. So this business of latent obstruction is as real as it gets. When should I suspect HCM? Look at the symptoms. The symptoms look like, if this were a board exam question, I would be going down the CAD route or whatever route, right? Dyspnea, dizzy, syncope, chest pain, palpitations. And the symptoms are dynamic. Symptoms are dynamic. I often joke they're kind of like my wife's moods. They change frequently. And the patients can be asymptomatic, right? So it is absolutely important to look at family history, autosomal dominant, unexpected deaths in the family. Take a thorough family history, sudden deaths, heart failure, stroke. Murmur, a dynamic murmur that changes with provocation with Valsalva, changing, squatting to standing, all kinds of stuff. Abnormal ECG, sometimes the ECG may not be that abnormal. Arrhythmias. So all these things have to be incorporated as you take into account these patients, come to a right diagnosis. This is a paper we published last year, 3,393 well-characterized asymptomatic Cleveland Clinic patients. We took a lot of pains in making sure these were asymptomatic at presentation. About 40% classified as obstructive. And when we followed these up, the patients who were truly non-obstructive, their survival was similar to age, sex match United States population compared to the obstructive population, okay? So we need to be moving towards true ascertainment of symptom status, and can we do something earlier? And we're going to talk about that. The business of latent obstruction. So from the same data set at the Cleveland Clinic, about 1,300 patients had stress echo. Okay? And what we found was in this asymptomatic population, about 22% had latent LVOT obstruction. You come in, walk in the clinic, I have no symptoms, let's run on a treadmill, 22% had significant obstruction. And the ones with obstruction did far worse. The ones where we recognize obstruction, followed them closely, and when they developed early symptoms, we sent them for a myectomy, they did very good compared to age, gender matched population and non-obstructive patients, okay? So we have to question the reliability of their symptoms as you evaluate these patients. Imaging, TTE is recommended transthoracic echocardiography, obviously the full bells and whistles, and ASC as well as the AHA guidelines have very nice documents of how to do these imaging studies step by step. So I would strongly urge you to take a look at those. CMR, complementary for if TTE is inconclusive, or for some additional things. There's new data emerging about LGE and extracellular volume, all kinds of fancy stuff. Sometimes for planning, you also end up needing transesophageal echocardiography. And in 2026, it is absolutely important to recognize 10% patients may have phenocopies, so you may need to do other techniques like amyloid scans, et cetera. So full picture, you have to have a 30,000 bird's eye view and then hone in onto specific things. So think your choice. 50-year-old man presents with exertional dyspnea, palpitations, chest pain, you suspect HCM. What's your next test? All right, echo, excellent. So a good lift, 66 to 88%. We are gonna make the unsure ones into assured ones soon. So we are also living in the world of AI, and this is data from Yale New Haven, not New Haven, almost 300,000 echoes. And what they found was using this AI, leveraging AI, they were able to identify 58% patients earlier in terms of a diagnosis of HCM. So you can potentially consider treating them early. Similarly, a lot of stuff is happening in the space of AI to make an early diagnosis using ECG. Now there are so many studies. Last year I published one of the earlier studies. Now there's a meta-analysis. God bless meta-analysis, right? But bottom line is area under the curve, sensitivity, specificity are excellent. But you have to make sure the patient population is well characterized because you do not want a suboptimal patient population. So what works for your center needs to be validated in your center. So with that, it is my privilege to introduce Dr. Owens, who will talk about how we have gotten here in terms of medical therapy. What has gotten you guys in here? Anjali.
Thank you so much, and good morning, everyone. So we'll jump into some data after that introduction, and we're going to start by looking at the mavacamten long-term extension data. These are patients who were enrolled in the pivotal phase 3 Explorer trial, obstructive HCM that led to the FDA approval of mavacamten. So those patients were followed over time, and this data is 3.5 years on mavacamten, and what you can see is sustained reduction in LVOT gradients on the order of over 50 millimeters of mercury with Valsalva. Again, remarkable changes from very abnormal resting gradients and Valsalva gradients down to normal gradients, no obstruction left. NT-proBNP that's down, and an LVEF that has decreased by mechanism of action, about 73 down to 63%. Now again, that's an aggregate, the whole population of 230 patients. Individuals within that group, as you're treating your patients in clinic, may have a more mild excursion of EF, no excursion, or a more severe excursion, and that's why we do individualized dose titration and monitoring. Almost 80% of patients improved by at least 1 functional class NYHA. And again, this is remarkable because we don't see that level of improvement on the traditional AV nodal blockers, beta blockers, or calcium blockers. Looking again at the Explorer cohort, this is from MAVA LTE, we now broke it down by the duration of diagnosis. So how long had the individual had HCM as a diagnosis before they started mavacamten? And we broke it into 4 groups, as you can see here, 0 to 2.5 years, 2.5 to 5 years, 5 to 10 years, and then those individuals that had been diagnosed over a decade before starting MAVA. And again, this is pushing beyond to say, what is the right time to start myosin inhibition in patients with obstructive HCM? And we looked at a number of factors, including the Valsalva gradients and the left atrial volume index. And again, this is to get a marker of how much adverse remodeling does this heart have, and what does it take to reverse that? And as you can see here by the overlapping lines, that all patients respond, regardless of their duration of diagnosis. But as you'll see if you look into the data more, which we presented at AHA, you don't always get to normalization, particularly of left atrial volume index, for example, if you've had a duration of disease that's longer. So I do think that we'll be pushing towards timing of starting therapy in terms of whether or not earlier should be better. When we looked at that favorable cardiac remodeling, again, this is over 30 weeks of time, we saw the classic features that characterize HCM improve, and that's wall thickness, mass index. The real hallmarks of the disease are being modified by the use of myosin inhibition, and that data is shown here by CMR. This is the VALOR study long-term extension. So this again was the second phase 3 for the mavacamten program. This was looking at much sicker patients, all of whom were being actively considered for septal reduction therapy, either with myectomy or alcohol ablation. A smaller cohort, over 93% were class 3 at baseline and on maximally tolerated meds. A fair proportion, 20% or so, were on disopyramide, my friend's favorite drug, and another high proportion were on both beta blockers and calcium blockers. And we know that the primary data at that 16-week endpoint favored mavacamten heavily over the background therapy. And what we see here is that over 128 weeks, the vast majority of individuals were able to avoid the need for invasive therapy. And so when you talk to your patients about that, most patients, not all, but most would say that they'd rather try the medicine first. Now, you're gonna have patients who say they don't wanna do that, and they prefer to go for a myectomy and have their one surgery, and that's fine, and that option should be available. So these are the discussions that we need to have in 2026 so that our patients can make informed decisions about their health. And we know that being on mavacamten does not mean that you can't have a myectomy. Now, what we're seeing in the real world is if mavacamten is used in a patient, for example, who also has concomitant valvular disease, primary MR due to MAC or other valvular abnormalities, or progressive aortic stenosis, in those complicated patients with concomitant valve disease, if you need to move to myectomy, you should hold the myosin inhibitor for a period of weeks so that it washes out prior to surgery, which is the protocol that we followed in the VALOR trial. What about the safety? So when this initial mechanism of action came about, there was concern from experts in HCM regarding what the long-term effect would be on safety of myosin inhibition as a mechanism of action. Here's pooled safety data. This is across 5 trials for the mavacamten program. And I'll call your attention to the AEs of clinical interest: atrial fibrillation, ejection fraction decreased, and heart failure. And what you can see over the years, it's year 1 all the way through year 5, is that there was decreasing, let me go backward here, amount of AEs over time. And again, that's reassuring. And one would hope that as you see the left atrial volume improving, that you would get less heart failure, and AFib over time. So I think the trend is that this is safe, durable, and effective. So here's data that translates into the real world what happens with healthcare resource utilization. So this is the shift that we all want to make. We are mechanistically affecting this heart, and how is it going to translate into clinical outcomes? Fortunately, our patients with HCM are not dying, certainly not at the rate of other heart failure syndromes like HFrEF or DCM. So we're not getting survival data this early, but we are now starting to see a decrease in hospitalizations for HCM-related, cardiovascular-related, and all-cause, a decrease in ER visits. Now again, this is claims data, so you'll take it with a grain of salt, but very encouraging to see a decrease in ER visits as well, and no change, a net of about even in the outpatient visits. And why might that be, that patients are coming back to clinic and it's evening out? Because we are doing safety echoes. So this is likely reflecting that patients are coming to clinic to get their safety echoes, but they're not in the hospital, they're not in the emergency room. Now again, we want to translate that to harder outcomes. Here's some real-world data from the Cleveland Clinic facilities in Ohio and Florida, and suffice it to say that the trial benefits that we saw have translated to the larger real-world population. We know these patients have more comorbidities, they're often sicker, they do have at times concomitant coronary disease. Nonetheless, we are seeing improvement in gradients, improvement in NYHA functional class. This is data hot off the press from ACC. It was presented yesterday by Jim Januzzi, and this is the Discover HCM Real World Registry. And what you're seeing is that the data are similar to what we saw in the trials. And I'll highlight at the top for you the symptomatic heart failure with LVEF less than 50% at a very low number. Not zero, so you do have to stay vigilant and pay attention to your patients. If symptoms are changing after a period of stability, bring them in, take a look, do that echo. Don't ignore it, but overall the rates were low and reassuring. Here's data from Marvel, again presented yesterday, hot off the press. This was presented by Matt Martinez. This was the Marvel real-world cohort of about 8 centers who are treating patients with mavacamten in the real world. And this sub-study looked at patients that had only provocable LVOT obstruction. So their resting gradient is normal. As Malin highlighted, you do need to do provocable maneuvers in these patients. That is the way to bring out the obstruction, particularly if they're symptomatic, because that's the only way to know if that's what's causing their symptoms. And I would encourage the clinicians in the room, have the patient eat a big meal, have them do whatever it is that brings on their symptoms in the real world, and try to recapitulate that in your echo lab. And in these group of only provocable obstruction patients who were symptomatic, we found that mavacamten was able to reduce that provocable gradient down to the normal level with a safe profile in terms of ejection fraction. So your patients in clinic, class 2, with no resting gradient, do that provocable maneuver, see if they have obstruction, and then you can try the treatment. Here's additional data. This was presented by Dr. Wong yesterday, again, hot off the press. This was an interesting study done via survey to look at KCCQ. KCCQ is a PRO, patient-reported outcome. You've seen it used in trials, but many of us do not use these sorts of measures in our clinics. May not be readily accessible, they take extra time to do, and so in the real world, many of us do not do them. But this was an interesting study to say, let's send them a KCCQ survey and see what happens. We also did the HCM SQ survey, which has been validated in HCM. And what you can see is improvement in both of these PROs. So back to that basic tenet with HCM, we want you to feel better, we want you to function better. And this is that important aspect of feel, and the patients felt better. This is another real-world cohort. This is a more diverse and global population in the real world of patients on mavacamten. And this is starting to get at the concept of what do you do with background therapy. And many of us are seeing that our patients no longer need or want to be on background therapy. So they'll come in and say, do I really need this other medication, the metoprolol, the verapamil, now that I feel well and my gradient is gone? And the answer in many cases is no, you don't, and you're able to withdraw that background therapy. Now, if your patient has a need for that medicine for some other reason, then by all means, you're going to keep them on it, but maybe not as that high a dose. And Melinda will talk to you later about a case of how you can adjust your blood pressure medicines. Hypertension, we know, is very common in these patients, and if you need it for that reason, you can keep it on or use a different agent. Again, this is additional MARVEL data, that 8-center cohort, looking at patients who were on mavacamten monotherapy, a smaller group of patients in this group, but very good reduction in symptoms, reduction in gradient. So you don't need the two groups to be synergistic. That's how the original trials are done, but we'll talk about moving beyond that and pushing the envelope into monotherapy. So before we leave this section, I will just call out to my friend Milind about a late-breaking trial.
Yeah. So in a few, 2 or 3 hours, this Scout HCM data are going to be presented as a late breaker. So be there. Unfortunately, I won't be there, but Joe Rosano, my friend from CHOP in Pennsylvania, is presenting this. Randomized phase 3 controlled trial in a pediatric population, so 12 to 18. So this is much needed. If we are talking about early initiation, here we go. And MAVA versus placebo, top-line results do suggest, as expected, favorable results for the primary endpoint. So be there about 11 or 11:30 is where it is going to be published with a simultaneous publication. So back to you.
Great. Now let's shift over to the next in-class cardiac myosin inhibitor. So first in-class agent, mavacamten, FDA approved in 2022 for obstructive HCM. We now have a second option, that's aficamten, approved in December 2025, again for symptomatic obstructive HCM. So let's look at some longer-term data for aficamten. This is the FOREST HCM study. So these are patients who were in a parent trial of aficamten and now have transitioned over to open-label treatment with aficamten. This is 168-week efficacy data, and I'll just call your attention to the graph with the NYHA class and the Valsalva gradient. And what you're seeing again is marked decrease in Valsalva gradients to the threshold that you get below 30, our definition of obstruction in this group in aggregate, and a change in NYHA functional class that's extremely favorable. People are becoming improved by over one class or equal to one class in 93% of patients. Now, all of this long-term data that's open label, we take with a grain of salt because the patients are knowing that they're getting the drug, but this is the data that we have for long-term extension. Importantly, in this group, there was no one who dropped their LVEF to less than 40%. There were transient excursions to less than 50%, which is what we see with this class of medications in terms of mechanism of action. This is data that is the latest phase 3 trial from aficamten, and this is the pushing of the envelope. So this is a landmark analysis because it is the first time that we saw cardiac myosin inhibitor, in this case aficamten, head-to-head against our traditional beta blocker therapy, which is metoprolol, mostly in the US, for obstructive HCM. So this trial looked at the peak VO2 assessed by CPET as the primary endpoint. And you can see here the aficamten arm in blue, metoprolol in orange. Over a 24-week treatment period, the aficamten arm went up by just about over 1 ml per kg per minute. That was very nice to see and confirmed what we saw in Sequoia, really, maybe not to that extent, but over 1 ml per kg per minute. But what started to be surprising is that the metoprolol arm decreased. Now, I'm a heart failure cardiologist by training, so I said, yeah, I know. Metoprolol can do that to you, chronotropic incompetence, et cetera. So, yeah. And the least squared mean difference between the two, as you can see, is quite marked. 2.3 mils per kg per minute, highly statistically significant. Then we delved down into the secondary endpoints, NYHA functional class, NT-proBNP, and gradient. And here's where we really had to pause and ask ourselves, what are we doing with metoprolol? This was a titration scheme that was meant to get people to the highest dose tolerated of metoprolol, with the vast majority making it to 150 or 200 milligrams daily of metoprolol. And you can see that the NT-proBNP got worse in the orange arm in the middle, metoprolol, and it got predictably better with aficamten, as we've seen again in the Sequoia trial. And then further, you look at the gradient and you say, why am I treating patients with metoprolol? I'm trying to make them feel better, function better, reduce their gradient. Only we didn't reduce the gradient. And again, this is an aggregate. These are all the patients from MAPLE. Within that subset, there may have been people who did get better on metoprolol. So take it with a grain of salt, but in aggregate, we said, this makes us question what we're doing. And then you say, well, if it's not working for efficacy, what's the data on safety? And the data on safety from this trial was good in that in the majority of areas, there was equivalence between the two drugs. There was one patient in the aficamten group who transiently dropped their ejection fraction to less than 50. And there were more episodes of hypotension, dizziness, bradycardia, fatigue in the metoprolol group, which is no surprise for those of us that use metoprolol, particularly at high dose. So what's coming at ACC that hasn't come yet tomorrow? There's going to be an evaluation or further data from the pooled group of Sequoia and MAPLE patients looking at aficamten versus beta blocker. And there's a new cardiac myosin inhibitor that is now in development. So I'll call your attention to this, which will be a late breaker of featured clinical research tomorrow. This is a drug that doesn't yet have a name, BHB 1893. This is their phase 2 study conducted in China. The results will be released tomorrow. Phase 3 study is ongoing. So let's talk now about integrating CMIs into our care.
All right. So this is awesome, right? Lots of data. For almost, 60 years, it was faith-based medicine. Now we have trial-based medicine. So it is good, right? And the guidelines have reflected this, rightfully so. ACC/AHA recommendations now, you still start with beta blocker or non-dihydropyridine calcium blockers. If symptoms persist, then they give you a buffet of choices, myosin inhibitors, septal reduction therapy, and personally, I have no idea what disopyramide is doing there, but Anjali, what are your thoughts about that?
I'm not on the guideline committee.
Neither am I, so that's why we both are here, so we can talk freely about it, right? But in real life, right now, most of us would start with a beta blocker. Symptoms persist, then as Dr. Owens said, give the patient a choice. And most people say, before I get cut, let me try the pill. If that don't work, we move to SRT. The MAPLE trial, and you rightfully highlighted, the last time I put a person on 200 milligrams of Toprol XL was somebody who I did not like. No, I'm joking. Was almost never. Yeah. Okay, almost never. So it's going to be interesting how the guidelines, Steve Almond, my very good friend, your good friend, how they're going to navigate this. Because look, at the end of the day, when the rubber meets the road, the beta blockers are generic, and there's cost and all those things. So if you have a 20% patient population that responds to appropriately use beta blocker at a reasonable dose, then they may be able to not, so there's a lot to be, I think the guidelines will guide us, but the battle will be won and lost at a higher power level called the insurance companies. What do you think?
Yeah, it's really the beginning of the discussion, right?
Yeah.
It's the eye-opening moment where you take a step back and say, what are we doing? Yeah. But it's not the end of the discussion, it's the beginning. And I think
exactly.
that's
Absolutely.
what we need to do.
Absolutely. So this is a very busy slide. And my strong recommendation is look at the dosing titration practice aid. But bottom line is, for mavacamten, you start 5 milligrams once daily if your EF is more than 55%, and then there's a dose titration scheme that is driven by gradients as well as ejection fraction cutoffs with echoes monthly for 3 months, and then if everything is stable, you go to 6 months. Max dose is 15 milligrams. Bottom line is there was a change in the REMS guideline where instead of doing echoes every 3 months, now you can do every 6 months if everything is stable. With aficamten, again, start at 5 milligrams. There's some flexibility of getting an echo between 2 to 8 weeks, and then you up titrate according to the ejection fraction. The bottom line, the difference between the two titration schemes, there's some complicatedness to it, but the termination or the interruption, the drug interruption for aficamten, the cutoff for EF is at 40%. We are not going to learn this in this hour-long session, but strong recommendation, you get used to the nuances using the practice aid. Important, drug-drug interaction, these drugs get excreted through the cytochrome P450 system. And last year, me and Dr. Owens had the ultra privilege of diving deep into the cytochrome P450 system. So you can look at the reference, expert opinion, drug safety. We did a very deep dive analysis into the cytochrome P450. MAVA has contraindications with strong CYP2C19 inhibitors, inducers, CYP3A4 inducers. So bottom line is, not unless you are a board-certified pharmacist here, I'm not, this you will have to rely on your friendly neighborhood pharmacist to help you with this. Aficamten originally started off with not much DDIs, but there are DDIs. So the label says contraindicated for use with rifampin. Long story short, if you are using CMIs, work closely with your pharmacy colleagues. And there are some common drugs, some SSRIs, the proton pump inhibitors. There are things you cannot use, and just develop in your mind what are the alternatives to use, and then the beat goes on. But make no mistake about it, you have to think about CMIs. This is Anjali, you.
Okay, we're going to move to REMS data. So this is 34 months from the mavacamten REMS program, again, real-world data that continues to show safety. This is almost 12,000 patients who are getting the drug-drug interaction checklists, which are completed for the patients every month. And what you can see here is a very small group on the left-hand side, less than 1%, much less than 1%, that resulted in either a mavacamten dose reduction, discontinuation of another medication, or discontinuation of mavacamten itself. So these things are navigable. You can do it. You just, as Milind said, have to be cognizant that there could be an interaction so that you're aware of it. And again, the feared complication of systolic heart failure with a heart failure hospitalization, someone who's really in trouble, is very, very small in the real world. And that's reassuring to all of us that we can use these agents safely for our patients and provide them benefit without a high risk of harm. And again, if you are that one patient that gets into trouble, your cardiologist better be aware of it and pick it up and treat accordingly. These medications are reversible. So if someone gets into trouble, you stop the medication if they're in heart failure, and then you restart it when you need to. So if there's symptomatic heart failure, that's when you be careful, but it's very rare, fortunately.
And one thing, Anjali, go back to that slide for a second. 76% patients were on 5 milligram dose. So that's the starting dose. So vast majority of the people, you start on a dose and you don't have to worry too much about up titrating. So important to note.
Yeah,
Sorry.
and the average dose in the real world is between 5 and 10 milligrams, which is similar to what we saw in the trial for mavacamten. For aficamten, which we have trial data for, but not yet enough real-world data, the typical dose is between 15 and 20 milligrams, so a little bit of a difference there. And as we have 2 drugs, and perhaps one day 3, 4, or 5 drugs in this class, it's important to know that they are in the same class, but they're different drugs, and that's why understanding the nuances of some of their pharmacology is going to become important. So here's a patient, Michael. This is an AI-generated patient, at least his image. 38 years old, obstructive HCM. He comes for his follow-up visit. And this is a 12-week follow-up after mavacamten initiation in this case, and his 8-week echo showed a post-Valsalva gradient that was already less than 30. It was less than 18. Now, this is not an uncommon scenario, and his 12-week echo is performed. And you can see there that he has normal labs, normal blood pressure. He's on metoprolol succinate 50 milligrams as a concomitant therapy. And his past medical history is pretty unremarkable. So here's his 12-week echo, and I'm going to play the images for you here. Ejection fraction, again, you want to take a note of, remains in the normal range. He's at 62%. His gradient at rest is 9. His gradient with Valsalva is 18, and you can see there that he has pretty good outflow and no obstruction, normal EF. So let's revisit Michael. What do you do in terms of the algorithm for titration? You now have a patient who's through that first 12-week period, and you look at their ejection fraction, which is remaining above 55%, and you look at the gradient, which is now less than 30. So you've now taken a patient from obstructed to non-obstructive with normal contractility. And that's the sweet spot where you want to be. You don't want the contractility to go too low, but you also don't want a really hyperdynamic obstructed heart. So now you're in the sweet spot, and the answer would be, let's leave him on the same dose. He's now reached maintenance. During that first 6-month cycle where you space out the echoes, do a clinical status check after about 3 months. And again, this was a little bit lost in the REMS, but check in on your patient. Doesn't mean you have to bring them to the clinic. Make sure they're okay, and then you can move out to every 6 months. So there are scenarios, perhaps we can get to this in the questions and answers, send few in, where you might titrate outside of the algorithm in the real world, and we're happy to address those things, not as USPI guidelines, but as real-world management of these patients. So based on his 12-week echo, what are we going to do to optimize his OHCM treatment? We better get 100% on this one. There we go, it's growing. Yeah, so you've reached the sweet spot here. There's no need to decrease the dose. There's no need to increase the dose. Right now, with our current knowledge, we're titrating to minimal efficacy, right? That means when you resolve the obstruction, relieve the symptoms, you're done. Now, I would submit to you, as we go further along in our journey with CMIs, and as we learn what to do for non-obstructive HCM, we might be saying, do you go to maximally tolerated drug, right? What do you do to get maximal amount of remodeling or outcomes? We're not there yet. Right now, guidelines are to use the minimally effective dose. So I'm going to pass it over to Melinda for our next case.
So this is Diane, again, an AI-generated image, 58-year-old patient with obstructive HCM presenting for follow-up. This is happening every single time you see these patients. Initiated MAVA 4 months ago after, because of symptoms despite metoprolol. But also she's 58 and there's other realities of life, including hypertension, which continues to be a problem for her. You can see the blood pressure this is stage 1 hypertension, heart rate is well controlled, everything echocardiographically is appropriate, chemistries are okay. BNP has normalized, and she's on 10 of metoprolol, MAVA and 25 of metoprolol. The rest is basically unremarkable except for cardiovascular risk factor in a family member. So in the past, when we did not have these scenarios, what do you do with these patients? Because the guidelines say adding lisinopril or ARBs and stuff like that, they aggravate LV outflow tract obstruction. So you are left with the, back against the wall, not too many options. The drugs like verapamil and diltiazem can serve dual-purpose obstructive HCM and hypertension, but they are rather weak antihypertensives. And if you look at the JNC guidelines or the hypertension guideline, they don't come in the top 2 or 3, right? So, and additionally, adding verapamil diltiazem to beta blocker, you have a much higher risk of bradycardia and LV dysfunction, etc. So, bottom line is, we never really had good options. So now, we are in a different era. You can eliminate obstruction, make them non-obstructive, make them asymptomatic. Now you can go at it for their hypertension. So we have lots of patients who we start them on MAVA, make them non-obstructive, then down-titrate their beta blocker, calcium blockers to relieve their side effects from those, and then have at it with their with JNC guideline recommended antihypertensive therapy. So now, the way I envision it, Anjali showed, MAVA or CMIs are causing favorable cardiac remodeling. We know treatment of hypertension reduces a lot of cardiac disease, including stroke, and antihypertensive result in favorable cardiac remodeling. So we could be dealing with multiple avenues of how we end up in a reduction in improved favorable cardiac remodeling and better outcomes down the road. So we are truly, there's all these additional benefits that we did not envision when we were studying these phase 3 drugs. So revisiting Diane, initiating of a standard antihypertensive in the context of LVOT obstruction control is a very good thing now, right? It's controlled. So now you can start ACE, ARB, whatever if you feel like it. Certainly, in my opinion, I would not go higher on metoprolol A, weak antihypertensive, and the heart rate is better controlled. And no real reason to go up on the mavacamten dose because HCM obstruction is stable, right? So now, you can look at the scenario where the patient's blood pressures over a longer duration get improved. Now you have the double good whammy, for the lack of a better term. So how would you rethink your choice for the question? Decrease MAVA, increase metoprolol, add lisinopril, add diltiazem, nothing, continue to monitor in a hypertensive state? I'm not sure. Excellent. That's a beautiful lift, 30 to 81%. So there's Aaron.
Over to Aaron. Aaron is 62-year-old, obstructive HCM. He's been on a CMI for about a year and has been stable with 6-month follow-up. But he reports to you that he's newly feeling short of breath and having some palpitations. So in this scenario, you take a look at his exam, you see him in clinic. He's got a BMI of 29, which is pretty typical of our patients with obstructive HCM, heart rate in the 90s, blood pressure is okay. But his EKG shows atrial fibrillation. Chad's VAS score is 0. And you say, okay, you're on metoprolol and your rate is controlled, but you're in new AFib and your CMI is at a mid-range dose. So what do you do with atrial fibrillation? 1, in an HCM patient. 2, in an HCM patient who's also on CMI. And there's some important learnings and takeaway here for the real world. 1, we know that anybody with HCM, not just those on a CMI, anybody is at risk to develop atrial fibrillation. And in our cohort studies, we've seen as much to a quarter or a third of patients with HCM have atrial fibrillation. So it is common. And what we need to do is diagnose it because patients are at risk for a stroke and we know that they need to be anticoagulated regardless of their CHA2DS2-VASc score. So one, you need to screen patients for AFib. The way we typically do that is with a monitor. I would encourage you to consider a prolonged monitor to pick up those symptoms of palpitations if they have them, so you can see what's causing it, and wearable devices and other things that are available. And then you modify their risk for stroke by starting anticoagulation, and also look at the other risk factors, including sleep apnea, excessive alcohol use, obesity, etc. In our patients with HCM, they may not tolerate AFib. They feel poorly in AFib, and that's where we use not just rate control, but rhythm control strategies rather early. Before you get adverse left atrial remodeling, we use ablation and or antiarrhythmics. In our cohort, we found that the combination of earlier ablation plus antiarrhythmics is a very good strategy for keeping patients in sinus rhythm. If you have AFib on a CMI, bring the patient in, check their ejection fraction. That's a time where they are prone to drop the EF. So take a look at that, bring the patient in. Here's a summary of AFib risk with both the mavacamten program and the aficamten program. And I have the trials listed there. Additionally, for mavacamten, we have some real-world data. We will be gathering that real-world data as aficamten makes its way into the clinics. So something to keep an eye on in terms of patients with AFib. And again, anticoagulation is mandatory, regardless of the CHA2DS2-VASc. Even in a young patient, they're at risk for a stroke. Most of us use the DOACs, but if they can't get one or there's some limited availability due to cost, you can use regular old warfarin. All right, so what do we do for Aaron, who is coming with new AFib? And again, I'm expecting 100%. We've all had our coffee. We're about to start to the real meeting. And what is our answer here? Yeah, we're getting there. 94%, perfect, from 52 to 94. So you guys are awake, you're paying attention, I love it. All right, let's move on to the next slide. And I will leave it to Milind to give our takeaways.
So I think as we round off the bases, this is, hopefully we have emphasized enough that this is a common disease, equal opportunity offender. Imaging is key, precise characterization is crucial, and focus on not just the obvious, but the suspected, including latent obstructive disease. CMIs are paradigm shifters. We are moving the needle towards younger patients, less symptomatic patients, earlier monotherapy, et cetera. And this is all backed by solid real-world evidence, which does show favorable remodeling, safety, et cetera, et cetera, et cetera. So with that, et cetera, we will do some Q&As.
Questions. Yeah, send us some questions.
Yes, we have some questions.
Good. So,
how do you decide to drop background therapy after a person is doing well on CMI?
I'm happy to start. So, I've gone through phases. In the beginning, in 2022, I was doing what the trials suggested, which is that you add CMI to stable background therapy. That's how the drug was evaluated, mavacamten in that case. And then once stable, meaning gradient resolved, patient is stable, then I would start to reduce the background therapy. So that could occur as early as week 12, but it could also occur later as you titrate up the drug in those patients who need it. I will say that I've modified my technique, and I don't wait quite as long. So if there's a patient who's doing well, their gradient is reduced, and we're still in that titration phase, I will now sometimes back off the background therapy even earlier. Another practice that I typically do, because there is an interaction between calcium blockers and mavacamten, is if I'm starting mavacamten, I would reduce the calcium channel blocker straight away as I started the mava. With aficamten, we'll see what the real-world practice is. We do know that there's some hypertension as you resolve the outflow tract obstruction for both drugs. It's physiologic increase, so you do want to make sure that you're keeping an eye on the blood pressure as you background therapy adjust.
Yeah. So, I mean, nowadays, bottom line is after they reach a steady state at about 8 weeks or so, when we bring them back or discuss if they're doing well, then we are quickly down titrating. Earlier, as we were in the early weeds, we were a little hesitant. Now, my nurse practitioner, Sue, I think she is aggressive as can be, and bam, bam, bam. And most patients seem to be doing well. So I think in the interest of time, do we still feel there's a role of DISO? And have you used DISO in combination with CMIs? I'll take that.
I knew you would.
No and no. To me, I have Cleveland Clinic population pre-CMIs, about 3 to 5% patients were on DISO. Overall, large databases. Similar, I've seen numbers from Mayo also. Since CMIs came, 0. And the ones, I should not say 0. I mean, if there is a real reason for AFib or some other esoteric reason, the EP person may consider, but from my perspective, it has been 0.
And there is a question about what to do if someone's on both. And I would say what you can do if you have a patient who's on DISO who wants to transition is you can either wean them off and then start the CMI. But if your patient's highly symptomatic and sort of dependent on that DISO, then you can do a crossover. You can leave them on their DISO, start whichever CMI. Both of them have been shown to be safe with the use of DISO. And then once the gradient is down, then you come off the DISO. So you can do it either way.
There's an imaging question. Should we shift to exercise CMR in HCM? What's the expert opinion? One of my side gigs is I also direct CT and MRI at the Cleveland Clinic. So the answer is hard no. Not at this point of time, clearly.
It's a hard no.
Exercise CMR, most of it is done using perfusion agents. We are looking for, the answer is no. There's enough utility and enough expertise in echo at this point of time. That should not be on the table. The other is, do we want to tackle this? Oh yeah, you can tackle this. You have a preference, or better said, which one of the CMIs should we use and when? Thank you. There was a nice thank you there.
So, this is a discussion between the doctor and their patient, and what the patient's preferences are, and what their life is like. You take into account, and if there is a patient who wants to come in once a month and do the typical mavacamten protocol, then you do it. If there's a patient who has restrictions or prefers to come in on a variable cycle and wants to do 2 weeks the first time and 8 weeks the second, then you have that flexibility within the REMS. And again, these drugs are in the same class, but they are not the same medication. So learn about their pharmacology. The half-life is different. The side effect profile may be different. The drug-drug interaction profile is different. So learn about the differences and then tailor it to your patient, which at the end of the day is what we all want to do. We want the patient in front of us to feel better and be comfortable with their choice. And so what I do is lay out all the options. And end of the day, it's good to have options.
Yeah. So I do not claim any level of expertise in cardio obstetrics, but I am gonna go there. So clearly, in my simple mindset, cardiac myosin inhibitors have some level of teratogenicity, or they're contraindicated in pregnancy. At least that's how I've always thought of in the context of mavacamten. Do you believe that any of these drugs are safe in pregnancy?
We don't have data, right? And if anything, this journey or history with HCM has taught us is that we need data before we make decisions. So personally, what we do with our young women who are of childbearing age is we discuss surgery. We discuss myectomy. If you're symptomatic and you have severe obstruction and you would like to have a child, we typically do myectomy, healed, better, carrier pregnancy. Until we have data to show us, I personally am not using drugs.
So I will give you a real world example of this. I have at least one patient I remember in her 20s. I saw her in her early 20s. She was doing a master's, and she was, she didn't want to deal with surgery, recovery, all that. So we put her on mavacamten for a few years. She was on birth control, all that stuff, and she managed very well. Then 2-3 years later, actually last year, she comes back, she goes, I want to start a family. So what we did was we stopped the mavacamten. Sure enough, after the thing wears off, the gradient came back. We sent her to surgery. She recovered. Now she's on her way. So at this point of time, I heard some chatter about, one may be safer than the other, and I would concur 100% with Anjali, would not go there.
The other take-home point is that the vast majority of women with obstructive HCM do well with pregnancy. Mm-hmm. These are not patients that go into terrible heart failure and have a bad outcome with pregnancy. This is the vast majority. They do better with circulating blood volume that goes up. Their obstruction gets better. They often tolerate pregnancy just fine. And you're going to worry about them until they deliver and they're okay. But generally speaking, they tolerate pregnancy. If you have a patient who's really severe refractory symptoms, that's when you say, okay, before the pregnancy, let's get this taken care of. But the vast majority of our patients tolerate pregnancy.
And one of the questions, how do you manage patients who are truly asymptomatic with obstructive HCM, given that outcomes are similar, but CMIs may result in favorable remodeling? So I can take that. So that's sort of, first and foremost, the definition of true asymptomatic needs to be after diligent assessment, including stress echocardiography, and then shared decision-making, risk benefits, all that happy stuff. Do I put them on beta blockers? I certainly talk to them about it. If they tolerate it, I keep them on stress echo. I'll give you an example. There's always an anecdote. I have a patient with high gradient in the obstructive range, but truly asymptomatic, 13 mets on a treadmill, etc. His barometer was, every Thanksgiving, I go hunting for deer or whatever. So, America, what can we do? And he goes, I can drag a big, there's some lingo, a buck, 12-point buck, or some business through the woods. The day I cannot do that, I'll come to you. And I was so scared. I would do stress echoes every year, and he's doing well. Till just recently, Doc, I had to get a smaller buck this time because I was a little bit dyspneic. That's when we triggered an operation. He was not interested in a CMI. So, but the important message is shared decision-making. We are in a slight data-free zone, but careful assessment. In the paper we published, 25% of patients converted into a symptomatic state after, over the course of their follow-up. So, the guidelines, if you read the valve guidelines, they say, come back in 3 to 5 years. No. The answer is no. You need to carefully follow these people.
Thank you so much for joining us. We'll let everybody get to the rest of the meeting.
Thank you, and have a nice day.